We're now going to talk about abdominal trauma. Now, when we talk about abdominal trauma, you're going to ask me immediately about FAST scans. F-A-S-T. Okay? FAST scans. All right? I want to explain it in this way. A FAST scan looks at four areas. Your pericardium, your right upper quadrant, your left upper quadrant, and your pelvis. Now, is a FAST scan in of itself definitive? No, it's a prelude to a CAT scan. I'm talking about a clinically stable patient. In a clinically stable patient, a FAST scan is a prelude to a CT scan. Does it give you an idea of what's going on? Yes. Will you still get the CAT scan in a clinically stable patient? Yes. So I want you to look at a FAST scan as a prelude. It gives you clinical information, but the definitive information in a stable patient is the CAT scan. All right, so I want to make sure that you understand that. So now we get back to abdominal trauma. Now I want to separate abdominal trauma, like we did for the neck, into two areas. Listen carefully, because it's a little bit different, okay? We separate abdominal trauma into gunshot wounds and knife and blunt trauma. Let me say that again. Gunshot wounds and knife and blunt trauma. So let's talk about the gunshot wounds. Real simple. All gunshot wounds go to the OR. That's so important, I'm just going to say it again. All gunshot wounds go to the OR. Period, period, period. Why? Well, the problem is that you don't know where the bullet goes inside. Meaning, you could have an entrance wound and an exit wound, and it looks like it didn't go in a significant area in the belly. Well, guys, the ballistics now of modern ammunition is not just one of caliber, like the Dirty Harry movies where you had a big caliber 44 Magnum, but it's velocity. And it's the velocity where it makes the bullet go around in a lot of different areas, which causes trouble. And you can't tell until you operate where that is. If you think, now you've all heard about AR-15s. Now an AR-15 shoots, generally speaking, what's called a .223 caliber. And that is just a little bit bigger than a .22 caliber bullet. Now, you might have, when you were young, you might have shot little .22 caliber rifles at the circus where they're target shooting and things like that. So you could say, well, how can an AR-15, which is a military weapon and a civilian weapon, firearm, cause so much trouble? It doesn't have to do with the .223, meaning the .22 caliber. It has to do with the velocity. And the velocity is so great that that's what causes the damage. So please excuse me for going on about this, but I want you to understand that you have to be safe. All gunshot wounds go to the operating room. All gunshot wounds go to the operating room. All right? So that's easy, and that is done with, and that is there. So now, let's talk about blunt trauma or a stab wound. Blunt trauma or a stab wound. If you have three things, you're going to the OR straight away. Number one, shock. Number two, acute abdomen. Number three, distended abdomen, where the guy is way out there, blood in there. You're going to the OR. Let me repeat those three. Shock, acute abdomen, distended abdomen. If they don't have any of those, you get a CAT scan. So therefore, we don't do, in the United States, much anymore peritoneal lavages. We just don't. Why? They're invasive. Could you stick a peritoneal lavage in the bladder? Yes. Is that good? No. Can you stick it in the bowel? Yes. Is that good? No. So we generally, in this day and age, we do CAT scans on a patient who is not in shock, doesn't have acute abdomen, and doesn't have a markedly distended abdomen. All right? The bottom line is you got to be safe. Let me tell you another story. Now, you may think that, boy, this hill has a lot of stories and stuff like this, but I want you to understand that medicine is a learning process. It is a learning process. So let me tell you a little story. In surgery, as opposed to medicine, age is seniority. Age is, meaning the older you are, the more senior you are in surgery. So about, maybe 30, 32 years ago, I was in the emergency room and some guy came in with a stab wound. And I was on call, and I was there. And one of the senior surgeons happened to be there, good friend of mine. And the guy had a benign abdomen, wasn't in shock, no acute abdomen, no distension, and I was all set to send him to CAT scan. And the other surgeon who happened to be there, I was on call, but he happened to be there, and he was senior to me, said, Mark, what do you do? This guy's fine. Everything is fine. He doesn't need a CAT scan. Send him home. What did I do? I sent the guy home. About 6 hours later, came back in shock, took him to the operating room. He did okay. But I remember going to the M&M conference. You guys know what an morbidity and mortality conference? When my daughter was real little, she once heard me talk about an M&M conference, and she said to me, Daddy, she said, at the M&M conference, do they give you M&Ms? And I told her, yes, they do. And I brought home from the conference M&Ms. You'll see, when you have kids, you'll do things like that. But anyway, at the M&M conference, they asked me directly. They said, why didn't you get a CAT scan? Now, I'm not going to tell them, well, there was a senior surgeon there who wasn't on call and kind of advised me not to. I just put my head down and I said I made a mistake. So guys, if there's any question at all, you got to be safe. You just got to be safe. You understand? Be safe. If there's any question at all, get a CAT scan. Get a CAT scan and make sure that everything is okay. All right. Next. Let's talk about solid organ injuries. Listen carefully. The most common solid organ injury in blunt trauma in the adult is the spleen. The most common solid organ injury in the teenager is the spleen. The most common solid organ injury in the child is the spleen. But the most common solid organ injury in the infant, not the child, not the teenager, not the adult, in the infant is what? The liver. Guys, if you've ever operated on an infant, they're all liver, meaning you open up their belly and they're all liver. Their liver is huge compared to everything else. So remember, that's a trick question, and you'll be asked it. It's only in the infant where the liver is the most common solid organ injured. Okay? That's very, very important. Okay? All right. Next, the most common intraoperative coagulopathy is dilutional thrombocytopenia. Let me explain again. The most common intraoperative coagulopathy is dilutional thrombocytopenia. Meaning, you're operating. The anesthesiologist is transfusing blood. And all of a sudden, the patient is getting oozing all over, okay? The most common coagulopathy is dilutional thrombocytopenia. Why? Are you transfusing whole blood? No. Are you allowed to transfuse whole blood? No. If I asked for whole blood, would they give it to me? No. You transfuse packed cells. And you run out of platelets. And the anesthesiologist, during the case, after you've transfused like 4 units of blood, they'll say to you, do you want me to give platelets? Yes. The second thing that runs out, the first are platelets. The second thing that runs out are factors. So in other words, factors are important. Fresh frozen plasma. So the most common coagulopathy intraoperatively is dilutional thrombocytopenia. The second is dilutional factors. So now I want to teach you something that I taught you. Remember I told you that in other lectures, cell-mediated immunity, and you've got humoral immunity, and both are important, but if you had to choose which is more important, it's cell-mediated immunity. And remember when I talked to you about acid-base balance, that you got acidosis and alkalosis, they're both bad, but which is worse, acidosis? Okay, well, when we talk about platelets and we got factors, platelets and factors, they're both important. Which, generally speaking, is most important? Oh, platelets. Platelets, platelets. Guys, I'd rather have abnormal factors than abnormal platelets. That's why all these people that are on Plavix and aspirin, they're a surgeon's headache. Guys, I want you to understand that platelets, generally speaking, are much more important than factors. They're both important, but platelets, that's why surgeons hate aspirin and Plavix, drugs like that. All right, I just want you to understand that. So if someone gets oozy during an operation where you're transfusing blood, and again, in real life, the anesthesiologist will say, you want some platelets? Yes. And then they'll ask you a little bit, should we give some fresh frozen plasma? Yes. All right. Next. If a patient in the operating room becomes hypothermic, will they clot better or worse? They will clot worse. Now, you might think that with cold, you'll vasoconstrict, which is true. But remember that clotting is what? Clotting is an enzymatic reaction. And if you're cold, will that enzymatic reaction be faster or slower? Slower. Guys, do you know who the cause of intraoperative hypothermia usually is? Surgeons. Let me explain. An operating room should be in the 80s. It should be. You got a patient who has no clothes on, you're opening up their belly, things like that. They're losing heat. And you know what the operating room temperature usually is? It's in the 60s. And you know why? It's because the nurses are nice people. Meaning, if they see sweat on my forehead, they'll say to me, Dr. Hill, are you warm? And I'll say, well, maybe a little. And what they'll do, because they're nice, is they will turn down the temperature in the operating room. Guys, it's really not the way to do it. An operating room should be warm. If you've ever gone to a pediatric OR or a trauma OR, oh my God, you will sweat like crazy. And that's why the anesthesiologist is always covering with those bear huggers and things like that, always. So I want you to understand, if you want to do something interesting, go to the recovery room one day in your hospital and ask the nurses, as soon as the patients come out of the operating room, what their temperature is. And a lot of them will be below normal. So in other words, it's important to keep the patient warm. Why? Because in order to clot normally, you gotta be normothermic. All right, very, very important. Next, you operate on a patient who's you've been operating for hours and hours, and their belly is really tight. And you pull the fascia, the balls together, and it's really hard to do, and you close them up. And post-operatively, the nurse calls you up and says the patient is hypoxic and no urine output. Hypoxic and no urine output. What's the diagnosis? Abdominal compartment syndrome. And what that means is that the pressure is so tight from closing the belly that your diaphragms are high, so you're hypoxic. They're high, they're pushed up. And you've got so much pressure in your belly that you're not getting adequate renal blood flow. The treatment of abdominal compartment syndrome is opening up that patient. And when you open up an abdominal compartment syndrome, when you cut, it goes like this. Nowadays, we don't close bellies that are tight. We leave them open, we cover them sterilely, put them in the ICU, and a day later or 2 days later, when the swelling goes down, we close them. But I want to tell you that years ago, when I was an intern, we used to, the interns had to pull the belly wall together while the attending closed it. And we got a lot of abdominal compartment syndromes then. And do you know what we used to, I know you're going to be amazed when I tell you this. Do you know what suture we would close bellies with when I was in my residency and early years of practice? We would use wire. I know you can't even imagine. The wire that you see sternums, sewn up with, we used that in the belly. Why? Because it was strong. We don't do that anymore. But I just want you to understand, you never, ever, ever close a belly that is under tension, because you'll get an abdominal compartment syndrome. All right.